My topic was to hopefully give you an idea or give you some help on quality of life issues on the aging population, female aging population, especially with respect to female pelvic floor disorders. I have no disclosures, and the objectives I have for this talk pretty much came with the discussion we had over a beer or two with Carol. And she was really interested in making sure that we were able to give you some helpful hints and some tips of how to take care of the aging population. And my goal, or my charge, was specifically the female pelvic floor. So what are the female pelvic floor disorders? Well, it pretty much boils down to three basic areas. The lower urinary tract symptoms, or what's called LUTS, that we call LUTS, prolapse, both uterine, cervical, and rectal, and any kind of defecatory difficulty. So anything that has to do pretty much with the pelvic floor is our area of emphasis. These are all the quality of life issues I hear when patients come in to see me one way or the other. These are probably a lot of similar phrases you've heard from patients as well. And more recently, we hear a lot of this stuff about, I don't want any of that mesh stuff I'm hearing about, which has got everybody jumpy, but I'm not going to get into that today. So what is female pelvic medicine and reconstructive surgery? That's very confusing. It takes a while to actually get all that out. It's also known as urogynecology. Urogynecology is a much more popular label for this specialty. And it actually came from a combination of a bunch of gynecologists and a bunch of urologists together sharing the same focus on female pelvic floor disorders and eventually petitioning to the American Board of Medical Specialties and getting it recognized as a subspecialty. What's unique about this subspecialty is you can enter it through urology or gynecology, either way, depending on where your training is. There are now fellowships. There are over 40 fellowships throughout the United States. There were no recognized fellowships when I finished, so I was not able to go through any kind of fellowship training. But in 2011, the American Board of Medical Specialists let us submit a case list and apply for board certification. And so there's a group of 900 of us now so far that are board certified in urogynecology, roughly 1720 in the state of Michigan. So most of the areas around here have somebody that deals specifically with female pelvic floor disorders. So let's go through some of the common LUTs, or the lower urinary tract disorders. So this is easily an hour or two on its own. So I'm going to break it down just to a couple things to try to get highlights since I've only got an hour. And nocturia is probably the most common thing that I get in the aging population as far as women complaining of getting up at night. It is a major problem. There are four basic areas where nocturia seems to be an issue, and we'll start off with 24-hour polyuria. Basically, this is defined as 40 milliliters per kilogram per 24 hours, or easily understood more as about 3 liters a day. That's what's output. When you're at about 2,800 to 3,000 liters or milliliters a day, that's considered excessive fluid output in women, and makes you at least think about whether or not this is someone who's actually drinking too much water. So what is too much, or what is considered adequate fluid intake? We get this all the time. There's a lot of different things out there that tell you what's adequate. 6 to 8 full glasses of water, 84 ounces a day, a third of your body weight, or I've heard a half of your body weight, equals the total ounces that you should be getting per day. Drink with meals and when thirsty, or until your urine is clear. These are all the different things we hear when we're talking about water. The answer is actually all the above and none of the above, but drinking with meals and when thirsty is what the recommendation is from the National Institute of Health. And I'll get into that a little bit. So what is the evidence we have for what is adequate water intake? Well, there isn't much evidence at all. Back in 1945, the National Academy of Medicine, which used to be called the Institute of Medicine, and they've now actually changed their name to the National Academy to go with the National Academy of Education, National Academy of Sciences. And they were charged with the mission of figuring out what is adequate fluid intake. And they didn't have the data to tell them what was the proper recommendation. So they used the easy biochemistry ideas of the idea that it takes about a cc of water to metabolize a kcal of energy. And since the recommendation at that time was 2,200 kcals per day to maintain ideal body weight, they just converted that to 2,200 milliliters of water a day. In their recommend, which runs roughly is about 2 to 2.5 quarts a day of water. So roughly, magically, 8 to 10 8-ounce glasses, or roughly 2,200 milliliters a day. So that's where all those rough numbers came from, was basically from this recommendation. The problem was this, and this is actually right from their website, the Institute of Medicine's website, and it looks really busy, so I made it a little bit easier to see. The recommendation in the box in the middle talks about the adequate intake for females, and adequate intake for females approximately 2.7 milliliters a day, and that's considered normal or average. In their recommendations, they also talk about the upper limits of normal. Question?
Did you mean 2.2 milliliters or liters?
2.7 liters or 2,700 milliliters. The other thing they have in their recommendations is there is no upper limit of normal. So there isn't a danger spot where you're supposed to be getting too much, whereas they did use that for sodium and they did use that for potassium. But for water, they didn't give an upper limit of normal. And that's because a more normal healthy kidney can handle a 0.7 or 700 milliliters in 700 milliliters per hour in a 24-hour period. So a kidney can handle it pretty well. Especially when they're young. Now, of course, it doesn't go with kidney disease, but for the most part, kidneys can handle that heavy water, with one exception, and I'll get to that in a minute. The other thing that was important about the recommendation that kind of got lost in all those formulas to figure things out is 20% of your daily fluid comes from foods. Apples, carrots, you're loaded with water. So 20% of that recommendation is food-borne. So really you got to subtract 20% from the amount of water that they're drinking from the get-go. So the most part, most women, or at least that I see, are drinking way too much water. A lot of times they think they need to do it because they need to be healthy. They need to make sure that they're getting their kidneys flushed. I don't know, Dr. Wardiger, do you need to flush your kidneys? I didn't think so. But it's a big thing to kind of try to push this water, and to see women coming into your office complaining of I pee all day long and all night long, there's easy tests you can do to try to help them with that. And of course, there's special considerations for the kidney disease. If your physician tells you you need to have this much water, we work around that, but for the most part, they're not told that. Weight Watchers is one of the worst offenders. They always push water, and it makes sense. Get water in the stomach, there's no calories. But nobody ever asks, do you have a problem with your bladder? No one ever asks that problem. So I see a lot of these women coming in. I can see Dr. Wardiger smiling back there. I see a lot of women coming in. That's the major problem, urinary frequency. Okay, so how can we improve their quality of life? Fluid management. Find out, are they drinking too much water? And the best way to do that is a test that's absolutely free, a little bit annoying for the patient, but it's absolutely free. That's a voiding diary. Voiding diary is nothing more than giving them a graph and we call it affectionately the hat. To put that on the toilet, they can measure each void, they can see how much volume each void is, they can see how often they're voiding, and you'd be surprised the number of times their eyes just get huge when they realize, oh my gosh, I'm really going. So it's a very simple test to find out. And this therapy, trying to get them to manage their fluids, works best when their fluid output is heavy. So if it's over 2 liters a day, you're going to usually make a big difference by helping them control their fluid volume. Now I apologize, this is kind of small to see, but this is just an example of a voiding diary. And this particular gal was putting out 3,700 milliliters a day on average. My record is 7,000. I had one gal day after day, she was putting out 7,000 liters a day. What's your record, Dave? 7,000 milliliters a day of urine output. And what was her complaint? I'm peeing all the time. And I said, but no doubt, you got kidney function and probably can't really concentrate very well anymore either. So, okay, so that's 24-hour polyuria. It's a very simple, easy thing to figure out. And the first symptom you hear from them is there's really not a big difference in their frequency between nighttime and daytime. And that differentiates between nocturnal polyuria. Not as much complaint during the daytime, but they're up every hour, every 2 hours at night. The definition of nocturnal polyuria is interruption of sleep 1 or more times by the need to urinate and able to go back to sleep afterwards. It doesn't really count when they get up and stay up in the morning, but that's just more for definitions. 41% prevalence in females between 60 and 79 in a study by Fitzgerald in 2007. So it's definitely a very common problem. Non-bladder causes, these are very high contributors to nocturnal polyuria. Mobilization of edema. You try talking to patients, you show them the swelling in their lower legs. That's accumulating all day long. When they go to bed at night, it's even with the heart, so all that fluid's going to dump right back in. Your kidney's pretty smart. It's going to get rid of all that fluid because it doesn't want the sodium level to drop. So basically, you're going to start peeing more at night. So trying to do something to mobilize the fluids, more exercise at nighttime, compression stockings, keeping your feet up between dinner time and bedtime, anything that can make that mobilization happen before they go to bed. Obstructive sleep apnea is associated with nocturnal polyuria. It triggers hormonal changes. The atrial natriuretic polypeptide will signal, it'll tell the kidney to start dumping urine again. They'll actually increase their output because of the sleep apnea, because of the positive pressure that's inside the pulmonary cavity. So correcting sleep apnea can actually help. Sleep disturbances that are associated with aging also should be addressed. I don't need to tell this group that. You probably see that a lot. And kidney disease, congestive heart failure, medications. Medications can make a difference. Medications screw up a lot of things in the lower urinary tract in our world. And you have to kind of look at their entire medication armamentarium, because there's a ton of them, as you can see on the slide, that can throw off what they're doing. Anticholinesterases, medications we use a lot for the overactive bladder, are pretty much in every category. They cause a problem, probably more so than they fix things. There can be a complicated medication to use. Not only that, there's usually anticholinergic and many other medications. Medications used to control bowel symptoms, medications for Alzheimer's, antihistamines. These are all going to affect up and give them an anticholinergic load, which can be a problem. Bladder causes of nocturnal polyuria, excuse me, detrusor overactivity. They basically just have an overactive bladder. Now, you'll usually get symptoms that they're just as active during the day than at night. You won't get that as much of a discrepancy with detrusor overactivity. Painful bladder syndrome, not so much in the aging population, but it's, again, in the back of your mind. Outlet obstruction. Unlike Dr. Werdinger, we don't have the pup tent, but we do have a problem with prolapse. Women with prolapse, especially more of an anterior vaginal wall defect, that actually is sticking out of the vagina. It causes a kink at the bladder neck. So we actually get a valve, if you will. It kind of kinks off, and they have a hard time urinating. They can't empty their bladder. They go to bed with a full bladder, and that can be an issue. Especially when they finally lay down, that obstruction is released. Now they gotta pee now. Now they lay down, they can feel the urge, they get back up, they go to the bathroom, they try to pee because the prolapse is there, it gets in the way of them going to the bathroom, they get frustrated, they go back to bed. This goes back and forth. So sometimes correcting that can help. Hypocontractile bladder, more common in the age or neurologic disorders, but they have the inability to completely empty, so they're going to bed with a half a tank, they're gonna get up sooner. So these are all things to help. What can we do to help? Lifestyle and health issues to improve sleep. So looking into the sleep disorder, and hopefully you can help them with that. Optimize all their known medical comorbidities to see if we can, especially the fluid load, and cutting off caffeine and alcohol. Patients don't like to be told they have to cut out the caffeine and alcohol. And I always told, well, you don't have to. You can keep doing that if you want. It's not going to kill you. At least I don't think it's going to kill you, but it's going to be a bother. And if that's what you're coming to me for, I'm just throwing that out for you. You can do what you want with it. Okay, reduced bladder capacity, not much in our category. It's more going to be in the realm of the urologist. They deal more with this than we do, with the exception of the prolapse issues. Women with pelvic organ prolapse, as I talked about before, will come in with that kind of a problem. They cannot completely empty their bladder. So treating the overactive bladder, definitely, but be cautious with antimuscarinics. And I don't have time to get into that one. That one's a sticky wicket. But be careful using any of your antimuscarinics in the aging population. It really can affect their cognition. And giving someone with an overactive bladder an antimuscarinic can have them fall because their cognition has been changed. Is not a good risk-benefit ratio. Prompted voiding, that's something that's really helpful, especially in the age that are in the nursing homes, or you're being taken care of an elderly at home. Getting them up and going more frequently can actually make a huge difference. They can actually empty better, especially if they're having accidents. They're in the world of incontinence. This is one way to try to outsmart that by having them go much more often. And a bedside commode. Another thing that's really, you hear, it's amazing how often you hear, well, I have to go downstairs, down the hall, and circle around the corner, go through the garage, go out the backyard, go back up to the roof, and come back down. Well, geez, I would have lost it a long time ago. But if a bedside commode sometime can help just relieve that pressure. Problem I find is nobody really wants to have a bedside commode in their bedroom. It just depends on how bad the problem is, but most of I find patients aren't thrilled about that. And then sleep disorders. For time's sake, I'll go through that. Okay, so a little bit about the overactive bladder. That's the other common lower urinary tract symptom that we deal with. 90% of these disorders are definitely idiopathic. For the most part, you don't find a reason for why they have this issue, but it's a big business. By the American Urologic Association's recommended guidelines, they recommend at the very least, when you have someone come in your office with an overactive bladder problem, the physical exam, including a pelvic exam in the female, and a neuro exam. So doing a neuro screen is also recommended, and a urine analysis. That's it. So a physical exam, including a pelvic exam, a neuro screen, lower extremity neuro screen, and a perineum, and a urine analysis. That's it. At that point, if you screen for significant diseases, you can move on to treatment. And first-line treatment by the AUA and SUFU guidelines. SUFU stands for the Society of Urodynamics and Female Urology. I think they've just changed their name again to make it even more confusing. But these are all available on their website. This is AUA.net. And their very first-line treatment is as simple as trying lifestyle, behavioral changes, and you can start medications early on with all these lifestyle and behavioral changes right from the get-go to try to make things better. So using medications, I don't want to get the impression that they're bad. You just have to be careful. I see a lot of these women coming in with at least 20 or 30 different medications. I'm more worried about interactions than anything else. These are common medications. They're around. The data on using these medications is not very good. The dropout rate after 6 months is pushing 70%. So it's not the best therapy we have. There are newer medications coming out. The newer class of bladder medications, the beta agonist medications, can help. They're much less side effects, but most of them are not covered by insurances yet, or just now starting to get it covered. And there are more medications coming out soon, so hopefully we won't have as much of the problem with those. So with overactive bladder, again, behavioral therapy, prompting their void, make them go frequently before they get to that urgent spot where they have to, and you can figure this out with a voiding diary. You can get an idea where they're losing urine, where they're having their leaking episodes, or where they're having their trouble, and try to tighten that up a little bit so they can go more often. It gets to be a little bit hard, especially if you have caregivers, trying to get, keeping them up and moving along. Weight loss, weight loss. There's studies done with weight loss. Women that are overweight, you can actually cut their urinary incontinence rate in half by just cutting back on a very small amount of weight. It was very impressive, so that's why that's considered a first-line treatment. Physical therapy. I've had very good luck with physical therapy. I love physical therapy. And if you've got, I think the secret to physical therapy is not just writing a script for physical therapy. I think the secret is going out and finding your physical therapist and finding out what they're doing. And if they're doing it right and they really like it, especially when patients come back and say, she was amazing, that's someone to hang on to, and don't tell anybody else. Just keep it to yourself, because you overload her and you won't be able to get your patients in. But it's really a problem, because not every physical therapist knows what they're doing. It's not as simple as just Kegels, which I'll get to in a minute. Medication. So yeah, a couple of things. If you must use medications, you got a problem because of this insurance coverage business. But trospium, or known as Sanctura, That's now generic, and so you can actually get that a little bit cheaper. Trospium is actually shown, at least in the lab studies, that it does have less of a cognition effect. It's a quaternary ammonium ion, so it does not cross the blood-brain barrier like the other antimuscarinics do. Mirabegron is the Myrbetriq, which you probably have all heard of or seen before. That's the first beta agonist that came out in the United States. There's many more in Europe, and they're soon to be in this country too. They're not there yet. Advanced treatments we have for this, the percutaneous tibial nerve stimulation is very low invasive, but not quite as good as sacral neuromodulation, but it's a very simple test or technique to use. Patients come into the office, basically we put an acupuncture needle just behind the medial malleolus where the tibial nerve is, and we give them 20 minutes or 30 minutes of stimulation, and they do that once a week for about 12 weeks. Response rate is so-so. Definitely nocturia. We see a very good rate with nocturia, not so much so with an overactive bladder. And the problem with PTNS is it doesn't seem to have holding power. After the 12 weeks, they're pretty happy. The insurance won't cover it any further than that, so they come in for once a month maintenance. And usually after 5, 6 months or so or sooner, that'll start to fade, and you won't see as much of a benefit with that. There are no studies out yet that compare PTNS with the second item here, the sacral neuromodulation, otherwise known as Interstim, which is Medtronic's product to do sacral nerve stimulation. That is a device that's with them all the time. It's much more invasive. They have to go through a couple different minor surgery procedures to actually put these leads inside the sacral the S3 sacral foramen, and they can hook it up to a temporary pulse generator, and if they get improvement with their bladder, they can go back to the hospital and they get a permanent placement of like a pacemaker item. Neither one of these options, we have a clue as how they work. There's a lot of research out there that says, well, it's because but they never tell you really what's going on. They've got fancy diagrams and things, but no one really knows how the heck this works. But for some reason, when you send electric current to S3, either through the sacral foramen or through the tibial nerve, which is predominantly S3, it tends to make their urgency better. Hopefully someday we'll figure that out, but right now we have no clue. Now, Botox, the last one, that's the new kid on the block. Botox was kind of nice because we didn't really have much treatment options between medicine and sacral neuromodulation. It was a huge jump. It's like going from the first step of the ladder to the very top of the ladder. There really wasn't much in the middle. Botox kind of helped that a little bit. And basically, we use onabotulinum toxin A, inject that into the bladder, and that can actually give them some temporary relief. It lasts 6 to 8 months or so, and they can come back in for another injection if they want. It can be done in the office. It's not a very difficult thing to do. Costs about $554 for a vial of Botox, so they have to pay for that. But more of a nominal fee just coming in, and we do it cystoscopically in the office. Pretty good response rate for them. About 8% of the time, they'll need to self-cath. So some offices, my office included, we recommend or we require them to show us that they know how to self-cath first, just in case they're in that 8% risk and they can't empty. So those are the more advanced treatments that we use for lower urinary tract symptoms. I'll move on now to prolapse. Prolapse is probably more bread and butter for urogynecology. We see more prolapse probably than anything else, other than maybe urinary incontinence. Excuse me. So what is prolapse? Well, if this diagram comes out pretty good, this is from the Cleveland Clinic, and what's really nice about this diagram is it kind of shows you hopefully the arrow comes out here. Are you seeing the arrow move around? No? All right. Well, this is a cutout of a pelvis that's kind of superior lateral, and they took out part of the ischium here so you can actually see the whitish tissue that's covering up the vagina and the area in the rectum is basically the fascia that creates this hammock that holds all the internal organs up. And everything is actually sitting on this hammock of connective tissue. The problem is when women have babies, that the babies come through and kind of do their number on that fascia, and some more than others, so we see prolapse in different degrees at different times of life. So this diagram is kind of trying to get you an idea of what the fascia looks like that we keep talking about in there. It doesn't look like this in the operating room. It doesn't look like this in a pelvic exam at all. It's an ideal picture to kind of give it across. We use this with residents to understand it. The better analogy is to think of the vagina as hanging on a suspension bridge. And if you consider the sacrum and the pubic and the pubis as being the two towers of the Mackinac Bridge, these ligaments on the top, the PS stands for the PUL stands for the pubourethral ligaments, and the ATFP is the arcus tendineus fascia pelvis, and the USL are the uterosacral ligaments. Those are the ligaments that are actually suspending the vagina and the uterus. And they pretty much start at the center and fan out to the side of the pelvis. That's what is holding up the pelvic organs. And a lot of different issues. Number one is having babies. Having babies increases your risk 8 times of having any kind of pelvic floor disorder. And probably through a destruction process, the baby delivering through the birth canal. But it doesn't happen to all. I've seen women who have delivered over 10 babies and have absolutely no prolapse and no urinary symptoms. And I've seen women that have never had a pregnancy and they have all these problems. So it's not the whole story, it just increases your risk. One of the theories on pelvic support also is the puborectalis muscle. If you look at the blue arrow, the faint blue arrow, what that's showing is the direction of muscle tone that the puborectalis, which is part of the levator ani muscle, and it's actually holding up the pelvic floor, creating this 130-degree bend to the vagina. And if you think about it, sometimes when you're doing a speculum exam on a female, you put the speculum in, you got to kind of find the cervix sometimes. And it's not just because it's tipped, as they say, but sometimes it's because that puborectalis has actually pulled up enough that it makes a little bit of a bend in that vagina. So typically, aiming down, you'll find the cervix if you're having a hard time finding it. But what that does is it creates the proximal vagina in more of a horizontal position, and you get opposition between the anterior and posterior walls of the vagina. Very important for support because you've got increased levator tone holding up the vaginal walls up against each other, helps women stay or helps prolapse from happening. Now here's an example of a break in that puborectalis muscle between the pubic arch or the pubic bone and because the puborectalis starts at the pubic arch and wraps behind the vagina and the rectum and then comes right back up to the pubic arch. That muscle creates what we call the genital hiatus. That is part of the levator plate, which are all the muscles in the pelvic floor. What can happen if that muscle breaks or tears or stretches is you lose opposition between the two walls. So the anterior and posterior vaginal walls no longer are opposed, and that allows gravity and pressure and physics to take over. So the arrow is showing pressure coming down on that anterior vaginal wall, and that's how we think a cystocele develops. So the pressure is pushing on the bladder because when they're standing, the pressure is all straight down. And that can also drag the uterus down, stretching that ligament. And then we have the argument as who's first, the uterus prolapse creating the cystocele, or does the cystocele happen first creating the uterus? That's up for us to debate. But nonetheless, that's how the current belief is how prolapse happens. So how can we improve their quality of life? There's a couple things we can do. We can observe it. We don't have to do anything. And we'll talk about that too. Pelvic floor exercises, pessaries, and then I'm not going to get into surgery too much today. We don't have time for that. But there's a great study that was done in 2012. And I minimized the studies on here, but this study is a fabulous one because they took 64 symptomatic women that chose expected management. They did not want surgery. They wanted to not do anything. So there's a bias in it. But it does show you the power of what happens afterwards when you examine them objectively. So these women came back between 6 and 91 months after their first initial evaluation. And they were evaluated with something we call the POP-Q exam. The POP-Q exam is a way to objectify prolapse. Instead of just saying it's out, it's kind of out, it's not really out. And that's kind of what gynecologists did for years, and they used just kind of a rough gauge as what was going on. POP-Q was developed by a research team that was international, it was throughout the entire world. And the intent was to keep it as a research tool, but it has eroded into clinical practice. And if you're doing a lot of prolapse work, this is pretty much our bread and butter. But nonetheless, it's an objective way to measure centimeters of prolapse. In other words, we use the hymen as the 0 point, and depending on whatever's prolapsed, if it's beyond the hymen, it's plus centimeters. If it's inside the hymen, it's negative centimeters. So that gives us an objective read. So they watched these women over time. 33% of these women that came in here had prolapse that was at least 2 centimeters beyond the hymen. So that's rather advanced prolapse. Most women are symptomatic when it's beyond the opening of the vagina. 78%, when you look at the outcome, 78% of these women, there was no change. And it didn't matter how far along their examination was, whether it was 6 months out, 10 months out, and 91 months out. There was no appreciable difference between the groups. And 3% actually regressed. So 3% of these women that actually came in, their symptoms regressed. They had less prolapse when they came in. So the conclusion of this study is there's very minimal progression of prolapse, especially in this group of women that did not want surgery. And that kind of led to the most common theory we have now for prolapse, which is called the bungee cord theory. Dr. Delancey at University of Michigan pretty much coined this. And if you think of a bungee cord and you start to pull on it, there's a stretch. Keep pulling. Eventually you're going to get to a point where that bungee cord doesn't stretch anymore. That's what we think prolapse does. We think these ligaments have an inherent elasticity, but you get to a point where there's no longer going to be any stretch. The problem is we don't know where that is. So observation is definitely a realistic way to follow these women if their symptoms are minimal. Kegels. Arnold Kegel it's not Kegel, it's not Kogel, that's a hot dog. Arnold Kegel was a gynecologist on the University of Southern California, and he published a paper in 1948. That's how old that paper is. And basically he was looking at incontinence, and his theory was if I get these women to squeeze this muscle, I can build up that urethral sphincter, as we call it. Unlike the males, the women don't have a sphincter. We call it the sphincter because it's a muscle that wraps around, but you can't ideally squeeze it like you can your rectum. But his thought was if we exercise those muscles, the hypertrophy around the urethra can help with incontinence. And that was the birth of Kegels or Kegels or Kogels I hear all kinds of different things for that. But I thought that was kind of neat. There's actually a paper, and I looked it up, and there it was. Pelvic floor rehab basically is what we talk, the physical therapist, sending them into physical therapy to get this help. Randomized controlled trials have shown that there is an improvement compared to no treatment. Unfortunately, head-to-head trials has not been as positive with pelvic floor therapy, especially in the long term. There was a trial that was done that was comparing physical therapy with the sling, and they allowed them to cross over after 6 months, and most of the women in the physical therapy group crossed over to the sling group. So it doesn't have the holding power necessarily. They're still trying to study why that is. But initially, for a highly motivated female with mild to moderate prolapse symptoms, pelvic floor therapy can improve what they're feeling. So definitely is an option. Plus, the side effects are zero. Other than your wallet, there's a copay issue that goes in with that, but the side effects are pretty minimal. Pessaries. Pessaries are the mainstay of gynecology, but they don't have to be. They're not a complicated thing to use. They've been around forever, as you can tell by these pictures. It's actually been written in the Pepiricious, which is the oldest medical textbook known. It goes 1,500 years back, and there's actually a discussion about the falling of the womb and placement of devices to keep that falling from happening. You can see on the upper right corner, the gentleman is actually placing a pessary, and that doesn't look like a modern snapshot, or what do they call those things now? Today, that's an old lithograph. The device on the lower right corner is actually this harness type device that women would wear. You'd put one of these pessaries on that little cup in the bottom and slide this thing up like you'd pull up your drawers, and that would hold things up. There's a medieval one where it looked like a chastity belt and had a phallus attached on the inside, and they would actually put that on and then take leather straps and put those around the side to kind of hold things up. So these women were desperate. They'd do anything they could. Sounds terrible, but when you're having prolapse, you can see the difference. These are some more modern devices here. They're not that modern. They're made out of wood, they're made out of glass, they're made out of brass. The one on the very top was a very popular pessary. Even Hippocrates has got in his descriptions of taking half a pomegranate, dipping it in wine, I don't know what the wine does, and then put that up inside there to try to help with the prolapse. So this has been around for a long time. Now we're up to medical grade silicone, much easier device to use, and a lot more expensive than the rest of these things. But nonetheless, it's a great device to use. So who's a pessary candidate? Everybody. They all are. I haven't met too many that really don't fit the bill. There are some that don't work very well, and we'll get into that. Poor surgical candidates are perfect for pessaries, especially if you're trying to get them ready for a surgery ahead of time to make them be a little bit more comfortable before you get that. You can really make their day, especially some of the elderly. I can't tell you the number of patients I've seen in the hospital. They're just miserable with their prolapse, and a little silicone disc putting up inside the vagina, they can actually pee. They are so happy. And they can take the catheter out. So it's amazing what that little thing can do. So who chooses pessaries? The older the females are, typically they're more likely to want a pessary. And we use these when we're trying to gauge which is the best treatment for them. Not sexually active, a pessary is just one more hassle to mess with for them. So if they're sexually active, that tends to lean them to the side of not doing a pessary. And most of the time they will prefer surgery. When offered, the study by Kapoor back in 2009, he found out that when women were offered surgery versus pessary with no biases, that 2/3 chose the pessary. So women are interested in this device. Most of them just don't know about it, surprisingly, but they just don't know it's there. So I keep a couple in my pocket, and I can show them exactly what it is and how it's used. So who's likely to fail? Unfortunately, yes, we have failures. We have a lot of failures. The biggest problem we have is that genital hiatus. When the vagina is open because of damage, typically to the puborectalis muscle, it causes what we call a gaping vagina or a gaping genital hiatus. When the diameter of the genital hiatus is close to the length of the vagina, it's unity, that's pretty much a high failure rate. They can't keep the pessaries in. We have all different kinds of pessaries, but we need that puborectalis to kind of be the resistance to keep the pessary from falling out. So that's a big factor we look for. Rectoceles, which is the bulge of the posterior vaginal wall, does not respond well to pessaries at all. Just because of the physics, the pressure still goes around the pessary and it doesn't work. Smokers, I have no idea, but that's in one of the studies showed that smokers are more likely to fail a pessary. Doesn't make sense, but that's true. And lower stage prolapse. Lower stage prolapse has less symptoms. They're less likely to benefit from a pessary. They usually don't like the pessary. They just not have the pessary. But again, it's pretty easy to do and simple to try. I usually try to convince everybody to try it before you do surgery, because you can't go the other way around typically. It's a lot harder. Who cannot have a pessary? Well, these are pretty much common sense, but non-compliance is the biggest issue. If you can't trust that your patient's going to come in, that's a problem. I just saw a patient this morning who came from California. She went and had her pessary put in when she was there. It was a miserable experience. She was very uncomfortable. Didn't go back to see a doctor again for 3 years. Came in to see me because her bladder was a problem. She's starting her overactive bladder symptoms. So, asking her questions, well, she's had a pessary in there for 3 years, and she won't let anybody touch it. She wouldn't let me touch it. So I'm working on it. But someone's got to take a peek in there. That's where you get into trouble. That's where pessaries start to erode into rectums and erode into bladders. It's neglect. Neglect is where you hear bad things about pessary. I have never seen a complication with a pessary in someone who's actually being watched. So it's a great device. Follow-up, typically we'll see them every 4 months or so. Some of my star patients, I let them go a little bit longer, especially when they're having a problem. The biggest complaint they have is discharge. They don't like the discharge. Only 20% of women will be discharge formers. It's not an infection. They don't get an infection from a pessary. There aren't bugs embedded in the silicone. It's just their own bacteria that starts to overgrow because there's a foreign body in there. You put a marble in the vagina, it can do the same thing. Anybody's taking care of a little girl who's come in for a foreign body from their vagina, the same thing. You get a discharge, you get a smell. So they're easy to treat. When they have this, there's a concoction called Trimosan. It basically just alters the pH of the vagina, but it does work. It makes a big difference. It can actually cut back on their discharge, and away they go. Erosions, this is probably the biggest problem with pessaries, I think. We have problems with just pressure sores. That's what the erosions are. The pessary is putting pressure on the vagina. They have prolapse, and they're standing up, and they're putting pressure on this pessary. Eventually, what can happen is the tissue can break down. They get into bleeding, more discharge, and it can be a little bit of a hassle. Sometimes we have to use estrogen cream. Sometimes we just have them take the pessary out for a few days, and they're good to go. But it can be an ongoing battle, and then sometimes we end up having to go to surgery because we can't get the pessary to work. Urinary tract infections are blamed by using pessaries. The studies support it. You're going to get it in this group anyway. You definitely are at risk if you've got prolapse. If you've got a prolapsed bladder with retention, you're also at risk. So it's kind of caught between the rock and the hard place. Cranberry tablets, antibiotic suppression, that kind of thing can help that. So quickly, surgery, I'm not going to go into this too much, but this slide was done just recently, 2014, to kind of give you an idea what the lifetime risk of women are for having surgery for either a pelvic floor, some type of pelvic floor disorder, not rectal, only urinary and prolapse. But it's 1 in 5, or 20% of women will end up having surgery. Now the problem with this study is that the dates of 2007 to 2011. 2011 is when the FDA came out with their second warning telling everybody that mesh is bad. Mesh bad thing. Bad is mesh. Mesh is bad. It causes cancer. It's responsible for your tax problem. It's responsible for your house getting water in the basement. It's responsible for a lot of things. It's really bad. So now we have to live through that nightmare a little bit. But this study was taken during the time before mesh. So my guess is this number is a little bit lower now. There's not as much enthusiasm of putting mesh in women, even if they have low-grade prolapse. So the numbers may be a little misleading, but it's a good study that we used. She used Medicare data, reporting data, to actually get actual numbers of patients, how many are doing surgery. So it's very accurate to give us an idea about how prevalent these disorders really are. Surgical options, basically risk assessment's the first thing we do. Is this someone you should be taking to surgery? The surgeries that we do can be anywhere from complex to piece of cake. It just kind of depends what their issues are and what you're trying to figure out. So we go into their comorbidities, the frailty issues, previous surgeries, which really can increase your risk, of course. Their quality of life. What is this quality of life? Where are they? How much are they bothered by this? Is the family bothered, or is the concept that it is there bother them? What is it that's bothering them? Are they uncomfortable? Are they not able to do things they want to do? All that stuff goes in, and sexual activity is very important. I'll show you why in a minute. The study was done here, again, in 2006 out of Brown University. The risk of death for urogynecologic procedures is generally pretty low. And if you look at, they kind of compared the 60 age group with going up in the next 2 decades. And it does climb, especially in women over 80. So it's definitely something you have to kind of gauge, and it's all kind of common sense. Obliterative techniques. I'm not going to go into all the surgeries because that's at least a 2-week discussion. But obliterative techniques are important because this is something that's quite often forgotten and a lot of times not even mentioned. But what we're talking about is obliterating the vagina, completely sewing the vagina closed. And if you think about what a prolapse is a hernia. So if you're going to send a patient to go get a hernia repaired, the surgeon's going to tell them they're going to push the thing that's poking out back in and then close the opening. Well, we can't do that. It's the vagina. But the bladder is herniating out, the rectum's herniating out, the uterus is herniating out. So if they're still using the vagina, we really can't close it off. But some of these women that are no longer sexually active, have no intent to being sexually active, we can do a procedure called a colpoclysis. And a colpoclysis is a procedure that's, if you can make sense out of this photograph here, basically we take a rectangle of tissue off the anterior vaginal wall and a rectangle of tissue off the posterior vaginal wall, and then we invert the cervix. So we actually sew those two sides together. We got two denuded surfaces, and we just turn the uterus up. We don't even take the uterus out. And this can be done, I've done one of these under a local No general anesthetic at all. You can do it just under local and maybe light sedation. So women that have got comorbidities can have this procedure done depending on how bad the problem is. This sounds drastic, but these are some of the happiest patients I have. They are so happy because they've been places, they said, you're too much of a surgical risk, we can't take you to surgery. But this is something you can do that's really a low surgical risk. It only takes about 30, 40 minutes to do it. They're just happy as clams. They can't have sexual activity. Well, they can't have intercourse anymore. They can have sexual activity. They can't have intercourse anymore. So you got to be clear on that. And we spend some time going over the regret. Any questions about this at all? Is it clear up there? Maybe not. Okay, any questions at all about prolapse? I know this is kind of quick, but in an hour trying to get these in is a little challenging. Okay, let's get into some fecal disorders. We end the talk on the rear. Here we got, this is just a quick anatomy to remind everybody. A lot of people think the anal sphincter is a donut. It's not a donut, it's a conical structure, so it's got length and width to it. The external anal sphincter is actually a continuation of the levator ani muscles, and they kind of congeal near the end of the anus, and that becomes the external anal sphincter. The internal anal sphincter is actually a connection, or they are connected to the circular muscle of the rectum. And that actually ends at the bottom and becomes a little bit thicker, and that is your internal anal sphincter. They come from two different areas. The internal anal sphincter is non-voluntary, whereas the external anal sphincter is voluntary. You can actually control that, and you'll see how that makes a difference. This picture looks a lot like one you saw with prolapse, and that's because the puborectalis in its toned shape is also causing this kink at the rectum. That is the primary response, or is primarily responsible for solid stool continence. So this little kink in the rectum allows the rectum to fill. So the rectum will start to fill with stool until it gets to a point, and that's when it gives us the urge that something needs to be done. The internal and the external and internal anal sphincters as a group are predominantly responsible for liquid and gas continence. So that's the difference between how that works. Now, when the rectum is full, there is a reflex arc that causes inhibition of the internal anal sphincter, which is 85% of your liquid and gas continence. But it'll start to go down because of that reflex. So that's when the external anal sphincter kicks in. And that's when you're getting that up, okay, I gotta go. So you're getting that little test that's telling you something's going on. And we call that sampling, which is really important. When the rectum gets full, it causes that reflexive inhibition of the internal anal sphincter and causes just a little bit of stool to sneak down into the anal cavity. The anal cavity has all the sensories, tons of sensory in the anal cavity, but the rectum does not. So the rectum can't really feel this. But the anus is oppressive because it can tell, usually, under normal situations, solid, liquid, stool. So you can either say, oh my God, I gotta run, or nobody's here, I can let it go, or I got a few minutes, I go to the bathroom in a minute. That's pretty impressive when you think about that process. The anal cushions also that circle the anus are also contributing to continence by giving it a little bit of coaptation. But the sphincter mechanism is definitely the majority of what's going on. The rectal anal inhibitory reflex is what I was talking about. That's when the stool fills the rectum and tells the internal anal sphincter to relax, allowing some stool to sneak into the anus and let us test. That's the sampling concept. It's called the rare or the rectal anal inhibitory reflex. It's not responsible for continence at all because women and men that have Hirschsprungs, they don't have a rare. That reflex is gone and they don't have the incontinence problems. Okay, so now if you decide, okay, I'm going to let this happen. I'm sitting in the appropriate societal accepted spot for me to empty my stool. I'm going to go ahead and do that. What happens? The first thing you do is you tell your external anal sphincter, we're good. We're in the clear, we can let things go. So you let it happen. And when you do that, it causes this reflexive arc. It causes the rectal muscle and your abdominal walls to contract. And that causes positive pressure, pushes the stool past the sphincters, and you empty. It also causes the puborectalis to relax at the same time, which straightens out the anal rectal angle. All that happens at once. Once the rectum senses it's empty, it causes another reflex, makes the external anal sphincter to give you that little pinch that happens at the end where you feel your external anal sphincter tighten up. That's the normal way it's supposed to happen. Quite oftenly, what happens with women, we hear a lot about this, they can't feel like they can't get clean. They're constantly wiping, they've gone to the bathroom, they know they're empty, but they go and check their clothes after a little bit when they go in to go to the bathroom and they see just a little bit of stool there, or they wipe and they get a little bit more stool. Usually what that is a very weak external anal sphincter. And what happens is they'll get that pinch at the end that doesn't completely close off the anal canal. And that stool just sits there and it will just kind of dissipate out as the day goes by. Okay, that's your physiology for defecation on a Friday afternoon. But nonetheless, it's very important I think it's amazing, this mechanism, how this works, and how much we actually know about how it works, but how much I didn't know about how this works until I went into this field. It's pretty amazing. So how do we maintain continence? It's very complex. So we have to have a continent external and internal sphincter. We have to have a competent puborectalis. We have to have tone in there to maintain that anal rectal angle. We have to have appropriate anal rectal sensation so we can tell what's going on down there. Do we need to run or don't we need to run? Normal rectal compliance. In other words, the rectum has to be able to hold stool. It has to be able to relax as the rectum fills. And Dr. Werdiger was talking about the proctitis that happened with men that had brachytherapy or the radiation therapy. Known problem with low rectal compliance, and they were usually stool incontinent as well. So bloody and mucus, but also stool incontinent because their rectum just wouldn't hold. And they get into this rectal urgency. Colonic transit time, very important. If they've got a very quick transit time, they're going to have more chance of having liquid stool present itself to the rectum. So that's something that can be fixed. And then, of course, conscious control. Dementias, Parkinson's, very, very difficult. They can't have the conscious control, and a lot more incontinence happens. So a couple of definitions here. There's a difference between fecal incontinence and anal incontinence. Fecal incontinence is fecal material, whereas anal incontinence also includes gas. So when you're hearing those terms, they're quite often used interchangeably, but there actually is a difference. Anal incontinence refers to the sphincteric mechanism isn't working, doesn't matter if it's liquid, gas, or solid. Prevalence, extremely prevalent. There's a study that was done and printed in JAMA in 1995. It was a community in Wisconsin, and 154 or 153 of 2,500 households reported anal incontinence at about 2%. So that's pretty high, actually, when you think about it. Of the ones that were incontinent, 30% were older than 65. So the elderly patients are the high population in the fecal incontinence group. These are some medications that are there that are known to cause problems, to increase the chance. It alters sphincter tone. That's just there for your guide. I want to emphasize is there are warning signs as far as fecal incontinence, especially if it's new onset. It just comes out of the blue. This is something you need to actually be on the lookout for. Of course, weight loss, decreased stool caliber, all the things you know. Endoscopy, be on there. You want to use endoscopic evaluation early in the process in someone who's new onset fecal incontinence. If their GI evaluation has not been recent, you want to take them in and make sure they're getting scoped and need to be seen. This is a card that I think is very, very, very valuable. It's called the Bristol Stool Chart. If you don't know about it, you can get on, just Google it, or take a snapshot of my screen here. And I have a laminated card in my pocket. It helps me a lot. Every patient will tell you they have constipation, but they all have their own definition of what constipation is. The Bristol Stool Chart helps you understand what they are meaning by constipation, and they can put it into a picture. And most of the time they have a little wince when they look at this. Why am I looking at a picture of poop? But if they got a serious problem, they're usually pretty open to it. Bowel diary, you can do a bowel diary just like you can do a voiding diary. Very helpful. They don't like doing that. So quality of life. Again, behavioral and lifestyle changes, physical therapy can be done. The difference with physical therapy and fecal incontinence is it needs to have what we call biofeedback with it. The studies have shown that they do a much better job if you have them give a feedback mechanism. We do that with pressure catheters in the rectum, where you can actually instill water into this balloon in the rectum, and they can start to sense it, and you can actually improve that with time, having them know when they need to get to the bathroom sooner and know how to help strengthen up that anal sphincter mechanism. So it's actually very helpful. Oh, this is another one that's easy too. Squatting. That's the natural position to poop. Not sitting on the toilet, especially not the ones that are the ones that are high. They have those higher ones for the elderly, so they can actually get off a little bit easier. The problem is the legs are down too far. You've got a 90-degree, and it doesn't relax the pubis rectalis as easily as it does when you're in the squatting position. So an easy fix for that is to give them a footstool. And just keep the footstool right by the toilet so they can shove the footstool up and keep their knees bent. You want to have them flexed at the hips. It straightens out the anorectal angle, makes it much easier for them to defecate. Oh, just to make sure, physical therapy, I talked about that. And I think, oh, this is a nice quick, if you see someone that comes in with fecal incontinence, especially if it's liquid, a quick and easy fix for them, at least temporarily, is something called anal plugs. Most people don't know about these. You're not going to see those advertised on the news. But basically, it's just this foam cup that's got this wrap around it that dissolves when they put it in the rectum. And it actually could help seepage problems, so they're not soiling their underclothes often. Again, it's a temporary fix, but it's something that you can offer. They can get these online. They're very cheap. There's a new device that's actually a pessary coming out. It's got a balloon attached to it, so they can actually pump up the balloon, puts pressure on the rectum, can help with fecal incontinence as well. More invasive options, I'm not going to get into these too much. Sphincterplasties used to be really, really common. The problem is they're really, really not very good. They work in the short term for a year or two, but after about 4 or 5 years, you're right back where you were. So sphincterplasties, basically what we would do is make an incision and put the sphincter back together. They're just not as helpful as we thought they would be. A new thing on the market is titanium beads. They're magnetic, and you can actually put this in around the rectum. They get a little device that they can turn the magnet on and off, and it actually pinches the rectum and can keep it closed. It's new. We don't have a whole lot of bad things about it yet. Stay tuned. There may be more. And stem cells. We're in the process of working on stem cells. There's a lot of work on stem cells in pelvic floor disorders, and we can regrow rectal sphincter muscles, or anal sphincter muscles. So that's kind of where the future is. Questions? Okay, thank you very much.